Today we're going to talk about the updated treatment algorithm from the 6th World Symposium. Specifically, we're going to discuss how to escalate therapy in patients who have not reached that low-risk status, which is now our goal of therapy. No matter what initial treatment decision you've made, whether it is initial monotherapy, initial combination therapy, no matter what, you need to reassess the patient. And if after 3 to 6 months of treatment, whatever your initial treatment choice was, they are in a low risk category, that's great. We're very happy with that. That's where we want the patient to be. And at that point, you don't need to add any other therapy, but it's important to continuously follow them up. There's an important role for structured follow-up in patients to see if they remain in the low-risk category, because if not, you need to do something else. The structured follow-up involves a number of different aspects, and most people do this every 3 to 6 months, and some more frequently, some less frequently in a patient who has demonstrated that they're doing well for a number of years. The assessments in structured follow-up include really the history, the physical examination, your assessment of their functional class. Sometimes physicians repeat electrocardiograms, although I personally don't find that too helpful in making these treatment decisions. It's very common to repeat some sort of exercise test. We commonly do a 6-minute hall walk with the Borg dyspnea score. Many institutions do that, although some will do cardiopulmonary exercise testing. Many folks repeat echocardiograms very frequently. That's really valuable information. Basic laboratory studies are important. We're often adjusting diuretics, but extended laboratory studies such as BNP or NT-proBNP are important as well, and really important in terms of the risk assessment. We assess pulse oximetry usually at the time of the hall walk, and occasionally it is important to repeat a right heart catheterization. Often we do it after 6 to 12 months of therapy, but sometimes it needs to be done more frequently. Let's say you've done that structured risk assessment, and after the first 3 to 6 months, the patient is still at intermediate risk. At that point, you need to escalate therapy. For example, if you had started the patient on dual oral combination therapy, you need to escalate to triple combination therapy if they remain at intermediate risk. Or if you started monotherapy, you can escalate to double combination therapy. On the other hand, if after your first treatment choice you reassess them 3 to 6 months later and they remain in high risk, that's a very poor prognostic indicator, and maximal medical therapy should be considered with triple combination therapy, including a parenteral prostacyclin. At this point, you should also consider them for lung transplantation. A patient who remains at high risk, even after treatment, should be considered for lung transplantation if they are otherwise candidates for that. So let's say you've done your first assessment after 3 to 6 months, you've escalated therapy if needed, it's time to reassess them another 3 to 6 months later after your second step. So if you've escalated and they're now in low risk status, that's great. You want to keep them there. You don't want to change anything, but you want to continue the structured follow-up. Now, the comment about lung transplantation, it's that it really should be considered according to the local practices and the average time on the waiting list. There are some countries that really still just accumulate time for lung transplantation candidacy, and so some patients even at low risk might be listed. In the US, such a patient would not really be evaluated. Would have such a low score that they wouldn't be considered a candidate. But this algorithm is intended to be for international use, and so it's important to know that some places need to think about that. So if after your second step you're still at intermediate or high risk, again, you need to escalate. Maximal medical therapy is recommended, and at this point, you should consider triple therapy with a parenteral prostacyclin. However, in patients who are at intermediate risk and are on an ERA and PDE5 at that point, one could consider the addition of selexipag, particularly for the intermediate risk group. For the higher risk group, we would prefer a parenteral prostacyclin. And if you reassess them on triple oral combination therapy, including selexipag, or double oral and a non-parenteral prostacyclin, and they remain at intermediate or high risk, the substitution of an IV or sub-Q prostacyclin should be considered, and again, lung transplantation evaluation should be considered. And then the final section is that patients on follow-up with low risk status who deteriorate to intermediate or high, this is the importance of continuously reassessing them, should be treated with some sort of escalation of therapy, whether it's monotherapy to double or double to triple or changing to a parenteral prostacyclin. The point is you need to continuously reassess them and try to keep them in the low risk group. And if a patient is on maximal medical therapy and still in an intermediate or high risk group, one needs to consider listing for lung transplantation. The other things that could be considered are balloon atrial septostomy as a palliative procedure or a bridge to transplant in carefully selected patients, although remember this is a very high risk procedure for which a lot of expertise is required. So that's a summary of the algorithm. The whole point of the algorithm really is to continuously reassess the patient and try to get them into the low risk category. And if you reassess a patient and they're not in the low risk category, there needs to be some change in treatment, either the addition of a treatment or the escalation to a more aggressive type of treatment. And this is really because of everything we've learned with risk stratification. Driving a patient into the low risk status is an important thing for us to do to improve their long-term outcomes. So I've enjoyed talking to you today about the medical therapy, the updates in the algorithm, which really depend on risk stratification. Thank you.